My name is Jessie Merlin. I'm an assistant professor of medicine at the University of Alabama at Birmingham. And at UAB, I run a chronic pain clinic that's within an HIV patient-centered medical home, or a Ryan White clinic. And I do research on chronic pain and HIV as well. So there are a couple of hypotheses about why there's so much burden of chronic pain in HIV, or at least it seems that way. So one is that, mental illness and addiction are more common in HIV than the general population. And we heard some good data presented about, for example, depression and HIV earlier today. So, and mental illness and addiction are more common in chronic pain. So maybe it's just, the confluence of these things together. But the other hypothesis is that maybe there's something about the HIV virus that really makes people with HIV more predisposed to developing chronic pain. I'm going to be presenting some data tomorrow about that. So we've looked at differences in pain sensitivity between patients with and without HIV, and found that patients with HIV exhibit more pain sensitivity, even though I'm talking about people who don't even have chronic pain. Just patients with HIV, patients without HIV, none of whom have chronic pain. Patients with HIV have more pain sensitivity. And then when you look at patients with HIV, so patients who have a detectable viral load are more pain sensitive than patients who have an undetectable viral load, who are more pain sensitive than patients who don't have HIV. So maybe there's something about the HIV virus itself, and there's some animal data about envelope protein GP120 actually causing increases in pain sensitivity. So maybe there's something about the HIV virus itself that does this. And then we also looked at inflammatory markers. So we looked at a host of inflammatory markers that are associated with chronic pain, and found that IL-1 beta is actually more common in patients with HIV who have chronic pain than in patients with HIV who don't have chronic pain. So there may be some biological reasons why patients with HIV are sort of set up or predisposed to develop chronic pain. So to develop this study, one of the things we did was we did a lot of interviews, qualitative interviews with patients who have both HIV and chronic pain, asking about what they would want in an intervention like this. And so we found out a couple interesting things. So one is that there's a strong preference for group-based, at least partially a group-based intervention, because from what they were saying, what it really sounded like is because chronic pain can be so socially isolating and HIV can be so socially isolating, and having both of those things together makes things even worse, that having a group where you can actually go and talk about your HIV and chronic pain and everybody else is going through the same thing is actually a really valuable experience. And so having that group-based component, and then also having a peer-based component. So being able to see somebody who has both HIV and chronic pain, who's doing well from their chronic pain perspective, and modeling some of the behaviors like engaging in physical activity, like knowing how to manage their stress to better achieve pain management, things like that. Being able to see somebody succeeding in those things is actually really important. And people even talked in these interviews about having a sponsor like you would have an AA or NA or a mentor, in that peer role. And so, so the intervention that we designed actually incorporates both of those things. So we have a peer who's co-facilitating these group sessions with a staff interventionist. People also talked about the importance of having an expert, somebody who really knows a lot about chronic pain, to deliver skill-based content. And so that's the other role for the staff interventionist, is to actually deliver some skill-based sessions as well. So I think for me, we really were not expecting this information about groups and peers to come out as being so important, but I think it's probably, in my estimation, going to turn out to be one of the most important things about the study and about the intervention. Of course, HIV is a highly stigmatized disease, and so is chronic pain, and so is addiction. And so when patients have all three of those things, we have to remember how hard that must be. And I feel like, this is purely anecdotal, but in my experience, that addiction and chronic pain are two of the last things in medicine that not only do we stigmatize without knowing it, but sometimes we, in healthcare settings, we really discount people with these problems. And when they have HIV on top of it, hopefully in HIV care settings, we're not stigmatizing patients with HIV to the degree that they might be stigmatized in other care settings, but of course we know that that still goes on. So when patients have these three problems, it can really influence how they interact with us. It can really undermine their care. And so one of the things I love about taking care of patients who have HIV, chronic pain, and sometimes also addiction is that, when you can help them, you're often one of the first people who's been able to help them. And it often really legitimizes their, how they're feeling and their symptoms. And it's a really wonderful experience. So I know some providers might shy away from treating chronic pain or treating addiction, but it is the most gratifying thing I've ever done because, when you can make progress, patients do well and they're so appreciative. And other providers are appreciative too. I think one of the most fun parts of my job is when I get a patient from another provider where they just really don't know what to do because it's outside their skill set and they're just sort of at the end of their rope and you can make some progress. That feels really good. But anyway, I kind of started with stigma and veered off in a little bit of a different direction, but it's sort of all related.